Aloha and welcome back to our series, Nursing and the Human Body. Today, we're going to talk about cardiovascular regulation. We're going to talk about hypertension, regulation of blood pressure in the body. And so let's just get to it. There are neural components of perfusion homeostasis. The automatic nervous system, or the autonomic nervous system, means that it's automatic. You don't control your automatic or autonomic nervous system. You do control your voluntary nervous system. So in the autonomic nervous system, we have the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system is our fight or flight. This gets our cardiovascular status all worked up when we are in fear, when we are angry, or when we have pain. You'll notice that your heart rate tends to increase in these situations. You need your muscles to run away from a threat. So what happens is that our blood gets routed to our muscles when our sympathetic nervous system gets stimulated. This sympathetic stimulation causes increased vasoconstriction of our blood vessels so that blood and oxygen can get to our vital organs. And that is why our heart rate is increased, our blood pressure is increased, and our airways are wide open. When our parasympathetic nervous system is stimulated, this is usually when we're resting and when we're digesting after a large meal. This is when our heart rate gets lowered and our blood is really shunted away from our muscles and it goes into the GI tract so that we can absorb all the good nutrients that we just ate in our big meal. We have baroreceptors, and these communicate with our brain. These are located in the aortic arch. They're sensitive to stretch or pressure within the arterial system. So this is another way that our cardiac status is regulated. These baroreceptors will stimulate the parasympathetic nervous system to decrease the heart rate and vasodilate the peripheral blood vessels when the blood pressure falls too low. So when the blood pressure falls too low, they activate the sympathetic nervous system to cause increased heart rate and blood pressure. We also have chemoreceptors. These are located in the aortic arch. And these are stimulated by increased arterial carbon dioxide and decreased arterial oxygen. So these chemoreceptors stimulate the brain to increase our cardiac activity and initiate changes in our heart rate and our arterial pressure. Why? So that the heart works harder to pump blood. We need to rid our body of carbon dioxide, and we need to increase the oxygen in our blood. Regulation of blood pressure. We're going to talk a little bit about the endocrine, renin-angiotensin-aldosterone system. Renin is an enzyme that's secreted by the kidneys, and it converts angiotensinogen to angiotensin 1. Next, an enzyme called angiotensin converting enzyme, or ACE, converts angiotensin 1 to angiotensin 2. So let's take a look at this. We can see our kidney releasing renin. We can see our angiotensin 1 converted to angiotensin 2, and this actually happens in the lungs. We'll talk a little bit about why that's significant a little bit later. So this angiotensin 2 is a potent vasoconstrictor. Vasoconstriction means that the blood vessels are constricting or getting smaller. And if you remember, we talked about when the diameter of a tube gets smaller, like let's say a blood vessel, it actually increases the resistance to blood flow. And what this does is it actually increases our blood pressure. The kidneys play a role as well. Many substances cannot pass through the filters, which are the kidneys, and remain in our blood. The kidneys contain millions of microscopic filtering units called nephrons, which are working components of our kidney. They help regulate the balance of sodium and water in our body. They excrete water-soluble waste and substances like sodium and water. So some substances pass through the filters like sodium and glucose, but other substances are reabsorbed back into our blood. So remember, we said that angiotensin II was triggered by the release of renin, and this signals our adrenal glands to secrete aldosterone. This is a hormone that signals the kidneys to retain sodium and water. If we're retaining sodium and water, there's a very good chance that if we end up with too much fluid on board, we will have an increase in our blood pressure. So this is another view of our renin and angiotensin system. We can see here our adrenal gland, which sits on top of our kidney, and we can see the adrenal cortex, which is the outer covering of the adrenal gland. The aldosterone is secreted by the adrenal cortex. The renin is secreted by the kidney. So what happens is when this renin gets secreted, the kidney signals the release of angiotensin II. This signals the adrenal cortex to secrete aldosterone, which is a hormone that signals the kidneys to retain sodium and water. When the kidneys retain sodium and water, there's an increase in the blood volume, which causes increased blood pressure. Antidiuretic hormone, also called vasopressin, is secreted by the brain in response to low blood pressure. It acts on the kidneys to retain water, resulting in increased blood volume. So here we can see a picture of the pituitary and our hypothalamus, just to give you an idea of where in the brain this is secreted. So if we look at this poster, we can kind of take a look at blood pressure control from these different body systems. So today, so far, we've talked about how the kidneys have impact on blood pressure, how the adrenal glands have an impact on blood pressure, and we've also mentioned how the hypothalamus or the pituitary gland has an impact on our blood pressure. So let's talk a little bit about blood pressure. As the blood is pumped through the arteries, it creates pressure within the wall of the arteries. So if we think about this cartoon and this animation, as the blood is pumping through the vessels are pliable, they're flexible, and we actually end up with pressure within the walls of our arteries because of the blood that's flowing through them. So as the heart contracts, this increased pressure is called the systolic pressure. As the heart relaxes and fills, this decreased pressure is called the diastolic pressure. Hypertension is high blood pressure, And a lot of times we just write this in our notes as HTN. Hypertension is measured by consistent elevation in blood pressure. So either a systolic blood pressure that is greater than 140 millimeters of mercury, diastolic blood pressure that is greater than 90 millimeters of mercury. And so what we're going to do now is we're going to kind of take a look at the different ways that hypertension is defined. Okay, because it's not just one reading that your patient gets at the doctor on one single occasion. Okay, so normal blood pressure is about 120 over 80, okay, or less. But we have these categories now, and these are new ones that were published in 2017, and it's the American Heart Association and the American Stroke Association have come up with these categories for us. So normal blood pressure is a systolic of less than 120 and a diastolic of less than 80. We get into a category where we call it elevated. The blood pressure is elevated when our systolic is between 120 and 129. And again, still, we're saying that the diastolic in this case is less than 80. We get into stage 1, high blood pressure, and we're actually calling it hypertension at this point, when our systolic blood pressure is 130 to 139, or our diastolic blood pressure is 80 to 89. In stage 2, we have a systolic blood pressure of greater than 140 or a diastolic blood pressure of greater than 90. Hypertensive crisis, which usually requires an ambulance, a phone call to 911, is going to be defined as a systolic blood pressure of greater than 180 and or a diastolic blood pressure greater than 120. This is a medical emergency. We're going to talk more about this a little bit later. So essential, and another way to say this is primary hypertension, is the most common form of hypertension. And really the cause of essential hypertension is unknown. However, we do know that there are many contributing factors to the development. And we call these risk factors. So there are different types of risk factors. There are modifiable risk factors, and these are risk factors that we can do something about. So for example, obesity is a modifiable risk factor for hypertension. Increased sodium consumption it's a modifiable risk factor. We can decrease the amount of sodium in our diet. We can go on a nutrition plan and we can lose weight. High cholesterol is another modifiable risk factor. Alcohol intake is a modifiable risk factor. Tobacco use and sedentary lifestyle. Why? Because we can make choices about these things. We can decide that we are going to lose weight, we are going to cut back on the amount of alcohol we drink, we're going to stop smoking, and maybe that we're going to get up and we're going to get off the couch and we're going to go out and we're going to exercise. And all these things, like I said, are modifiable. But there are also unmodifiable risk factors. Okay, so let's talk about what that means. You can't change your race or your ethnicity, right? And so we know that statistically speaking, African Americans have a higher incidence of hypertension, and that just has to do with their ethnicity. Gender is another unmodifiable risk factor for having hypertension. So for example, males tend to have more hypertension than females. And then family history also plays a role. So for example, my mother has hypertension. that means that I am at a higher risk of developing hypertension than if my mother never had hypertension. But I can't do anything about that, right? It's non-modifiable. So in terms of age, before the age of 65, hypertension is more common in men. And for women, we're finding that after the age of 65, we're seeing it develop in women. Socioeconomic status is also considered a risk factor for hypertension. The studies show that less education, less financial resources, decreased access to health care are all factors that can have an impact on a person's risk for developing hypertension. If you don't have the education to understand how to eat properly, how to exercise, that's going to impact your health. Same thing with financial limitations in terms of being able to go to the doctor, having health insurance, getting your blood pressure checked. So let's take a little bit of a case here. Here we have a gentleman. This is our friend, Mr. Watanabe. He's a 64-year-old male. He's a retired accountant. He denies alcohol or smoking. That means he's saying, I do not drink alcohol and I do not smoke cigarettes. He walks about 2 miles each morning. He eats a local Hawaiian diet. His father died of a stroke at the age of 80. He comes into the doctor and his blood pressure is 138/85. It's a little bit elevated. He will definitely need to follow up and have blood pressure checks and risk factor assessments. So like I said before, we don't diagnose someone with high blood pressure just because they come into the doctor's office once and they have elevated blood pressure. What we're going to probably want to do with this gentleman is we're going to probably send him home. We're going to tell him to continue with his exercise routine. We're going to teach him how to decrease the amount of sodium that's in his diet. We're also going to teach him how to increase the amount of potassium-rich foods in his diet, like green leafy vegetables. We're probably going to get some labs to see what his LDL and cholesterol levels are, and we'll talk more about those labs later. We're probably going to have him measure his blood pressure at home with the home blood pressure monitor and keep logs of those blood pressure checks. And then what we'll probably do is have him return in about 3 months, and we'll see what that log is showing. And so if that log is showing elevated blood pressures, and we're finding that the modifiable risk factors that he's changing are not making a difference in his blood pressure measurements, then it would be time to consider medication. So let's talk a little bit about secondary hypertension. Unlike primary hypertension, which we said doesn't necessarily have a specific cause, secondary hypertension does have a specific cause for elevated blood pressure. And in this slide, I'm giving some examples of some disease processes, well, certainly not in the case of pregnancy, but some conditions that might cause us to have secondary hypertension. So for example, when a woman is pregnant, she can develop something called eclampsia or preeclampsia, where her blood pressure is elevated. And this is just due to her pregnancy. And actually, once the mom delivers, she will not be hypertensive because the pregnancy is what caused the increased blood pressure. Diabetes mellitus is another secondary cause of hypertension, and this is usually because of damage to the kidneys. That's what nephropathy means. We know that kidney disease definitely is a secondary cause of hypertension. A little while ago, we talked about what an important role the kidneys play in blood pressure regulation. So it makes sense that if we had disease in our kidneys, that our body would not regulate blood pressure as well, right? Remember the word homeostasis, that balance? Very important. Obstructive sleep apnea is another known reason why people develop hypertension. If we put our patient in the sleep lab and we identify that they're having sleep apnea, which means they stop breathing in their sleep many, many times during the night, if this goes unchecked and undiagnosed, these folks will develop high blood pressure. If we put a CPAP machine on them at night, which helps them breathe better while they're sleeping, we've seen that their blood pressure can go down. There are neurologic diseases that can also cause secondary hypertension, and medications as well. And so what this means is that if we can treat the underlying cause, we might be able to treat the hypertension. But here's the thing about hypertension. It usually has no symptoms. It's usually detected on a routine visit to a medical clinic where we might see an elevated blood pressure. But here's the thing. If it doesn't have any symptoms, most people that have hypertension will not know that they have it until they get blood pressure readings that indicate that it's elevated. This is also the reason why you will hear people refer to hypertension as the silent killer. Because actually, hypertension can cause a lot of problems in our body. And if we don't get it treated, it can eventually cause health problems so significant that it kills us. But it also can be symptomatic. So for example, somebody could have a headache when their blood pressure is high. They could have visual changes, especially during stressful episodes, right? So people with hypertension, they might actually have some of these symptoms if their stress level goes up. They might get blurred vision, or they might feel that they're getting a headache coming on. But long-term untreated hypertension will damage our blood vessels, okay? And what happens is these blood vessels are exposed to high pressures. They become thickened and hardened, and this makes them less flexible. And we call this arteriosclerosis. So here we can see what a normal blood vessel looks like if we're looking in and down the blood vessel. But what happens in arteriosclerosis is this thickening and hardening, and this process leaves the blood vessel being less flexible. I'm going to show that animation one more time. So this is arteriosclerosis. But fatty deposits can also form on the arteries, and these are called plaques. And they can cause the artery to narrow and become blocked. This is called atherosclerosis. Now, it's really important as nurses that we identify that there's a difference between arteriosclerosis and atherosclerosis. So again, arteriosclerosis is the hardening of our vessels and in the narrowing of our vessels, but atherosclerosis is actually fatty deposits that end up on the wall of our arteries. Blood vessels that are exposed to high pressure can become thickened, hardened, and less flexible. And then the fatty deposits can cause these plaques, which cause our arteries to narrow and become blocked. So we talk about complications of hypertension. It's important to identify which organs can be damaged. And these include the heart, the brain, the kidneys, the eyes, and our peripheral blood vessels. So when the narrowed arteries become blocked and the blood supply to an organ is stopped, organ damage results. This damage is called infarction. Hypertension can also cause brain damage. It can cause a stroke. Other ways to refer to a stroke are a brain attack, a cerebrovascular accident, and a cerebral infarction. Those all mean the same things. And what happens is we can get pieces of plaque that break free, maybe off of one of our internal carotid arteries, and go up into the brain into smaller and smaller and smaller vessels until that little piece of plaque gets stuck in a very, very small vessel, and it causes an infarction. So let's take a look. So in this picture, what we can see is the area where the artery is clogged, and then the area above that artery where the tissue will not get oxygen-rich blood. This is where the infarction will actually take place. And we talked about infarction being cell or tissue death. The other thing that can happen with high blood pressure is that a weakening of the arterial wall can balloon out, and this is called an aneurysm. Now, what can happen with these high pressures is when the wall gets ballooned and weakened, it can burst. And if the wall of the artery bursts open, there can be a hemorrhage, in which case the patient is actually bleeding internally, which can cause death. And so we can see here the aorta, which runs right down through the center of our abdominal cavity, can get this aneurysm formed, and if it bursts, a patient can actually bleed to death. This is why it's so important for us to be monitoring our blood pressure. Here we can see where we had one of these aneurysms occur in the patient's brain. So what happened was long-term untreated hypertension caused one of the arteries in the brain to balloon out a little bit and eventually break open. And so in the case of a hemorrhage, what we have is bleeding in the brain. But this will also be referred to as a stroke. So the kidneys are another organ that is impacted by long-standing hypertension. Hypertension is the leading cause of end-stage renal disease. The damage results from the ischemia that's caused by the narrow lumen of the intrarenal arteries. And their job is to supply the kidneys with oxygen-rich blood. So if the kidneys aren't getting the oxygen-rich blood that they need, and the patient ends up getting kidney disease or kidney damage, this causes all sorts of other problems that we're going to be talking about when we study what the kidneys do. Remember, we said that the nephron were the individual functional units of the kidney, and there are over 1 million of these nephrons. And so small vessel damage inside the kidney can cause damage to these nephrons. There can also be target organ damage to the eyes, and this would be retinal damage, where a patient could have blurred vision, they could have retinal hemorrhages, and they can end up with blindness or loss of vision. So in hypertensive retinopathy, what we see a lot are these flame hemorrhages, these hard exudates, and these cotton wool spots that cause damage to the eyes. We can also end up with peripheral vascular disease. And what this means is that our peripheral blood vessels will end up getting atherosclerotic, okay? So hypertension can lead to atherosclerosis of the peripheral blood vessels. And these are the arteries that supply blood to our extremities. And one really good example of this is a term that we use called intermittent claudication, all right? This is when the patient comes into the doctor's office and says, you know, it used to be I could walk about 2 miles, and now when I walk my 2 miles, at the end of my first mile, I start to feel like some pain in my legs. And the pain is like enough that I kind of need to sit down and rest. And so what happens in intermittent claudication is that muscle pain in the lower extremity results from a temporary inadequate supply of blood or oxygen to the extremity due to narrowing of the arteries. So that's definitely a term that you're going to want to remember, intermittent claudication. It's when walking a certain distance will cause us to have pain in our lower extremities. What happens is that limits the supply of oxygen to our leg muscles. And it's going to be more noticeable when the oxygen requirement of our muscles rises, like with exercise and walking. Hypertension can cause damage to our heart, and we call this coronary artery disease, okay? So long-term sustained hypertension damages our blood vessels. If our blood vessels are exposed to high blood pressure, they become thickened, hardened, making them less flexible. And this includes the vessels that actually supply the heart. We can see changes in the heart muscle as well. We can see left ventricular hypertrophy. Hypertrophy just means that the left ventricle gets bigger. The left ventricle pumps oxygen-rich blood out to the body. And hypertrophy is an increase in the size of an organ. If we have left ventricular hypertrophy, we've got sustained high blood pressures that end up increasing the cardiac workload. The left ventricle works harder to pump and begins to grow larger to keep up with the demand. So let's think about this. When our muscles work, like when we work out, we're doing it to make our muscles bigger and stronger. Well, in the case of left ventricular hypertrophy, this is not a good thing. The heart muscle getting bigger is not better. This is really due to the increased pressure in the systemic circulation, especially at the level of the arterioles and the capillaries. And untreated left ventricular hypertrophy may lead to congestive heart failure. So on this image here, we see the normal heart, and we can see the right and left ventricle as they are normally. But on the other side, we see the left ventricular hypertrophy. Now notice that the left ventricle, the muscle has gotten larger. And what that's doing is actually decreasing the amount of space in that ventricle for blood to fill. Okay, so it's decreasing the amount of space in the left ventricle because the muscle has gotten larger. So we're going to talk more about congestive heart failure a little bit later. But right now, we're going to focus in on hypertension's diagnosis. So we said a little bit earlier that we said if it was a systolic blood pressure that was either equal to or greater than 140, or a diastolic blood pressure that was either equal to or greater than 190. And the important thing here, though, is that the blood pressure is measured properly on different days and even at variable times of the day. Here are some of the sites that we can use for blood pressure measurement. Most commonly, when we go to the doctor's office, we measure blood pressure at the brachial artery, where the cuff gets put around our upper arm, and we listen with our stethoscope over the brachial artery. But we can also measure blood pressure over the radial artery, which would be basically checking a blood pressure in our wrist. We can also check blood pressure in our popliteal artery, and this would be putting our stethoscope in the fossa, the popliteal fossa behind the knee. And then we can also measure blood pressure in the posterior tibial artery. So you'll hear people say they're going to measure the blood pressure in the ankle, and that's another place that we can measure blood pressure. So properly measuring blood pressure is really important for the nurse to know. We need to have our patients in a seated position. Both feet need to be resting on the floor, and it's also important that we use the correct size of the blood pressure cuff for the size of our patient. So the bladder, and I actually brought a couple of cuffs with me so that we can see that inside the blood pressure cuff is something called a bladder. And it's actually the balloon that inflates when we pump up the cuff. So this is the bladder. So this usually sits inside our cuff, okay? And the bladder should actually be long enough to wrap around the patient's upper arm, okay? So this is an example of the bladder wrapping around my arm. Now we can see a blood pressure cuff certainly is big enough to wrap around my arm, all right? But more importantly, we want to focus in on the bladder of the blood pressure cuff, which is really only from about here to here, okay? And where we want to place the cuff is kind of midway in the upper arm between the acromion process and the olecranon process, all right? So basically your shoulder bone up here and your elbow, okay? Right here in the center is where we want to place the cuff. The bladder in the cuff should almost or fully encircle the upper arm. And I'll show that to you again. So in this case, this bladder doesn't fully go all the way around, right? It almost does, okay? And that's okay. That's an appropriate size. What they say is that it should be about 80% to 100% of the circumference of the arm. So let's look at an example. Earlier today, I actually measured my own circumference of my upper arm. And what I found was that it was about 25 centimeters around, all right? So I took my measuring tape, I measured around my upper arm where we would place the cuff, and it's about 25 centimeters. So if an arm circumference is 25 centimeters, there should be a blood pressure cuff with a bladder that's at least 20 centimeters in length. And it's just a simple math calculation. 25, which is the centimeters around my arm, times 0.8, or 80%, is 20, all right? And so one of the ways that you can measure is really just to take the cuff, feel where the bladder is inside the cuff, and try to wrap this around your patient's arm. And it should almost wrap around. It's important that we use the correct cuff or bladder size, because if we don't, we'll get an inaccurate reading. So let me show you what we've got here. This is a really big blood pressure cuff. If you measured my blood pressure with this cuff, you would get a false reading, and you would probably get a reading that was too low, all right, a false low. However, if you measured my blood pressure with this cuff, which is more like pediatric size or very small adult size, you would probably get a blood pressure that was inaccurate and too high. What's important is to measure blood pressure with the proper size cuff. So this would be the correct blood pressure cuff size for me. And it even tells you that there's a range listed on the cuff. And on this cuff it says the range is 25.4 to 40.6 centimeters. Well, earlier I told you that I went ahead and measured the circumference of my arm, which is about 25. And so this would be the proper size cuff for me. The other things that will impact blood pressure, which need to be assessed for before you sit your patient down and check their blood pressure, is have they had caffeine right before they came in to get their blood pressure checked? Did they smoke a cigarette, or were they vaping right before they came in? Because caffeine and nicotine can both increase your blood pressure. That doesn't mean that you walk around with high blood pressure all the time. It might mean that your blood pressure was just a little high because you just drank a cup of coffee. The other thing that might cause a high blood pressure in the doctor's office is a full bladder. If your patient has to go to the bathroom, they might go, come back, and have a perfectly normal blood pressure reading, okay? Rushing around and not honoring a 5-minute rest period before we check someone's blood pressure will probably give us a false high reading. So actually the patient should be resting for 5 minutes, and oftentimes they do that in the waiting room before they come in. The other thing we want to consider is something that's called white coat syndrome. And what this means is that some patients have a tendency to have increased blood pressure just because they're in the doctor's office. They get really anxious when they're around the physician or the nurse. This is called white coat syndrome. And the blood pressure is elevated only when they are getting it checked at the doctor's office. So let's take a little bit of time here to discuss hypertensive crisis. This occurs most often with a history of hypertension, and these folks are what we refer to as non-compliant with their medications. It means that they don't take their meds, either because they don't feel hypertensive, they can't afford their medication, or they might not like the way the medication makes them feel. And so this is severe elevation in blood pressure, a systolic blood pressure at 180 or greater, diastolic blood pressure of 120 or greater. And what's happening during hypertensive crisis is that we are concerned about target organ damage. So we just went through a whole list of organs that can be damaged due to hypertension. And so this is also known as malignant hypertension. It's when the hypertension is severe enough to cause acute visual changes, neurologic changes, a stroke or a hemorrhage, and organ damage. We might have a patient that presents with nausea, headache, vomiting, confusion. They can end up having a seizure, and they can actually go into a coma. And what we usually do is we give them drugs that will cause vasodilation. That means that their blood vessels are going to open up. We would like to see those arteries open, and some of the drugs that we might give them in their IV are sodium nitroprusside or nitroglycerin is another example. If we have a patient that has had a hypertensive crisis, we want to make sure we're monitoring all of their vital signs carefully. We want to watch them for hypotension. What do you mean hypotension? You just said that they were hypertensive. Yes, but if we're going to give them drugs now to lower their blood pressure, we have to make sure that the drugs that we're giving them don't make the blood pressure go too low. We're also going to make sure we are checking their neurological assessment. Because what did we say earlier? We talked about the brain really needing good balance, and if it doesn't have good balance, good homeostasis of perfusion, then we can have brain damage. Brain's not going to work. A lot of times we will put these patients on bed rest. They need a very quiet, calming environment. Low lighting, decreased noise, decreased stimulation. We're going to strictly measure their intake and output because we want to make sure that their kidneys didn't sustain any damage during this hypertensive crisis. We're probably going to have them on telemetry, so we're going to be measuring their heart rhythm. And we're going to be doing focused cardiac and respiratory assessments. So we're going to be listening to their lungs, and we're going to be listening to their heart with our stethoscope. Now, if there is a situation where your patient could be hypertensive and have a crisis, that the blood pressure is too high, we can also have the opposite problem, when our patient's blood pressure is too low. And one of the things that we like to do is we like to measure something called postural blood pressures, all right? So orthostatic hypotension, all right, is when our patient's blood pressure drops because they go from a laying down to a sitting or a laying down to a standing position. And so the way we measure postural or orthostatic blood pressures is we have the patient lie down and we measure their blood pressure. We have them sit up on the edge of the bed and then we measure their blood pressure again. And then we have them stand and we measure their blood pressure a third time. From lying to standing, if we see that there is a systolic blood pressure decrease of more than 20 millimeters of mercury, it's significant, okay? If their heart rate increases by 20 beats a minute, or they become tachycardic, then this is also a significant finding from a lying to a standing position. So what happened? Okay, why did this patient try to stand up and feel dizzy and have to sit back down on the bed? Why did their blood pressure drop? Well, what happens is there's inadequate peripheral vasoconstriction in their arterioles and their veins, and venous pooling happens. So that means that blood is kind of pooling in their lower extremities. We have a decrease in the cardiac output because the blood's not getting shunted back up to the heart. The brain's not getting enough blood. We have low blood pressure, and lightheadedness might result where a patient feels dizzy. So there are different causes of orthostatic hypotension. We could have a medication be a cause of hypotension. Nitroglycerin is a drug that can cause hypotension. Diuretics like Lasix can cause hypotension. So we want to make sure that after we give a patient nitroglycerin, like for example, we might give them nitroglycerin for chest pain, we want to make sure that their blood pressure doesn't drop too low. Same thing if they're taking diuretics. Diuretics are going to flush fluid out of their body. And we talked about fluid having an impact on our blood pressure. So if they become hypovolemic, or the fluid volume in their body is too low, then they're going to be at a higher risk for orthostatic hypotension. So prolonged bed rest, laying in bed for long periods of time can cause this. Internal bleeding, let's say there was bleeding inside our GI tract and we were losing blood volume over time. Vomiting and diarrhea is another cause of hypotension because you're losing fluid, right? When you're vomiting or patients having diarrhea, they're losing fluid. And this is another reason that they can become hypotensive. So what do we want to do about it? If your patient feels dizzy when they stand, we want them to sit back down. It usually resolves when our patient returns to a sitting or lying position. Other ways we can prevent this from occurring is to have them sit at the edge of their bed, dangle their feet before standing, get them up slowly. Sometimes it helps when patients have problems with their venous return to give them compression stockings or TED hose. And we'll talk more about those when we get into some of our skills labs. And also increasing fluid intake. Sometimes it's really just a matter of being dehydrated. And so having someone sit down and drink a few glasses of water might really help with their fluid, with their lack of fluid and their dehydration to help increase their blood pressure. It's really important for us to review their medications. We want to know if they're taking any new medications that might be causing their hypotension. And we also want to find out if they're taking the correct dose. So let me give you an example. Let's say we have someone who comes into the doctor. They have had their blood pressure measured on several different occasions, and their blood pressure is deemed to be high. They're sent home with diet modifications and lifestyle modifications for 3 months, but they come back and their blood pressure is still high. Doctor decides to put them on, well, let's say metoprolol, 25 milligrams. Give them the prescription, the patient goes home, they fill the prescription, but they only take the medication every other day. Or they only take the medication when they feel like they need it. And they come back to the doctor for a follow-up appointment. And the doctor says, oh, so are you taking your medication? Yes, I'm taking my medication. And they get their blood pressure checked and it's high. And the doctor says, well, I don't think your dose of metoprolol is quite high enough, so we're going to increase your dose to 50 milligrams. They go, they fill the prescription. They're not taking 50 milligrams a day at home. Again, they might be taking 50 milligrams every other day or when they think they need it. Now they get admitted to the hospital for some other problem. And what do we do as nurses? We're following those doctor's orders. We're giving them 50 milligrams of metoprolol every day. And you go to get the patient up for a walk and boom, they faint on you because they're hypotensive from getting those doses of metoprolol that they weren't actually taking at home. So keep in mind that sometimes we run into these issues and we need to know if our patients are taking their medicine and if they're taking the correct dose. If we have a patient whose blood pressure is so low that they end up in critical care, we measure something called the mean arterial pressure. This is really considered to be the perfusion pressure seen by the organs in the body. So in other words, when we're looking at a mean arterial pressure of greater than 70 millimeters of mercury, we know that that's enough to sustain the organs of the average person. If our mean arterial pressure falls below 60, we've got a risk for our end organs to become ischemic. And this is actually how the mean arterial pressure is calculated. It's the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. So that's all we have for our slideshow today in studying cardiovascular regulation and hypertension. And we will study more interesting things about nursing in the human body when we come back next time.